Hey guys, it's Dr. Dan here. Welcome back to my channel. If you're new to my channel, I am a practicing orthopedic spine surgeon, and here on YouTube, I do a lot of teaching of medical concepts and surgical concepts through reaction videos of medical dramas. And the crowd favorite seems to be Grey's Anatomy. Today's video is the second part of Season 6, Episode 6, coming to you right after this. Before I get started, guys, I just want to thank you for being here and supporting my channel. If you don't want to miss any future reaction videos, please smash that like button, smash the subscribe button, and hit the bell notifications, and you won't miss a future reaction video. The other thing is stick around to the end of this video. At the end of the episode, I will be giving 2 scores, and I did this in my last reaction video. You guys seem to love it, which is I'm going to give a score for how realistic was this episode, and secondly, how entertained was I. So let's get started.
Crap, she's completely closed off. I can't see her cords.
You can't intubate a patient?
Of course I can. I was having trouble.
Her airway was completely closed off. I mean, I couldn't tube her either.
So I think it's pretty funny here that the resident was saying that he was having trouble with this patient, but Richard just immediately accuses him of, you don't know how to intubate a patient, which is unfair. So intubation is the process of using a tube called an endotracheal tube that gets placed through the mouth into the patient's airway. And this tube can then get connected to a ventilator, which can assist the patient's breathing. An instrument is used to actually raise this tissue flap called the epiglottis, and the doctor can actually see vocal cords, and that's actually where the tube actually gets placed in between. And this is what the resident is referring to when he says that the cords were completely closed off. The patient was so swollen that he couldn't see the vocal cords, and that's a huge problem, and this is a very difficult intubation.
Move, she needs a crike.
Amber back. She's got no landmarks. I was hoping that she would... You're going in blind?
So Alex rushes in here and says the patient needs a crike, which is actually a cricothyrotomy, which is a surgical procedure where an incision is made in the neck in between the cricoid cartilage and the thyroid cartilage, which actually can be felt here. That's the Adam's apple. It's an emergent procedure that's done when the patient can't be intubated through the mouth and you need to access the airway.
Let the carotid, let the carotid. Let the carotid.
All right, so Alex here is muttering over and over, don't hit the carotid, don't hit the carotid. And what he's referring to is the carotid artery, which is this very important vessel that runs in our neck that supplies the head with blood. It's kind of weird that he is so worried about hitting it because the crike is actually done very midline in the center of the neck. Carotid artery actually runs more lateral in the neck, so he's not really close to it, but it is accurate in the sense that surgeons are very worried about hitting critical structures, which are nerves and blood vessels. Surgeons hate hitting and damaging blood vessels. There's a lot of bleeding. All surgeons hate bleeding. So his worry here is accurate in that sense.
Got it. Start ventilating. She's got pulmonary edema. Switch to high frequency jet ventilation. Get a CBC, lights, ABG. Just shotgun her, get everything. She had ARDS, BP was dropping, we started fluid, she was sinking fast.
So Dr. Krev here mentions the patient has pulmonary edema, which means the patient has fluid in the lungs. ARDS is this condition where inflammation just hits the lung and it spreads throughout the lung. The lung cells actually become leaky and fluid comes in and fills the lungs. And it's a pretty dangerous condition and lots of causes for it. There's trauma to lung can cause it. Also, pneumonia can cause it. COVID-19 is known to be associated with ARDS. Alex here is trying to figure out what is causing the patient's ARDS, and that's why he orders this shotgun blast of labs. He says, let's just shotgun her. He orders, number 1, he orders a CBC, which is a complete blood count, what actually tells you what your blood levels are like. And number 2, he orders lights, which are electrolytes, also known as a basic metabolic panel or a complete metabolic panel, which includes measurements of things like sodium and potassium. And the third thing he orders is an ABG, which is a arterial blood gas, which determines things like the acidity in the blood, as well as oxygenation of the blood. And all of these lab values give the physician different data points to help them make a diagnosis for the patient.
BP 69 over 32, pulse is 158. We're already filling her with fluids. Yep.
She was acidotic. We pushed bicarb. They needed more hands.
So obviously the patient's very, very sick here. So one of the residents here talks about the blood pressure being 60 over 30 or something like that. And that's a very low blood pressure. And the blood pressure is a measurement of how well the blood is circulating through the body. And if the blood is not circulating adequately, this low blood pressure, also known as hypotension, then that's a problem. And the heart is actually working harder and it is beating faster. So the heart rate was in 160, something like that. And that's actually much higher than it should be. And that's tachycardia. The heart is working much faster to try to pump blood to the organs that need it. Alex also mentions that the patient is acidotic. There's increased acidity in the blood. What can cause that is hypoxia, or your organs not getting enough blood can cause acidosis. Overall, this patient appears to be in a condition called shock, where the body does not have enough blood to adequately circulate and perfuse the organs and the rest of the body.
Keep her on 100% oxygen. No, do not. Not until she is more stable. Kristina, scrub out. Go see if you can help. Go.
There was so much swelling, we couldn't find good veins. Well, we had to start a central line. Her CK level's over 75,000.
All right, so two things here. You see Dr. Yang actually scrubbing out to go help her co-resident. So this actually happens. And when I was a resident all the time, there's the attending's still in the room operating. So if my co-residents were actually overwhelmed in the ER, then I would leave the OR and go and help them. So that's actually accurate. So Dr. Kepner here mentions that they couldn't find any good veins and they had to place a central line. So typically when you give a patient medications or blood or fluid, you use these peripheral IVs, which are small catheters that are placed into the small veins into our arms and our legs. Now, if you can't access those for whatever reason, then you have to put in the central line, which is a much more involved procedure. And the catheter actually goes into vessels that are closer to the heart, the great vessels known as vena cava. And there's some advantages to this. You don't do this for everyone, but when you need to do it, it allows you to put in blood and fluids into a patient much faster. The central line can stay in the patient a lot longer. And so you're not going to do this for every patient, but if a patient you can't get access and you need to, then you would do a central line for.
She's got fulminant rhabdo. Everything was failing. The kidneys, liver, lungs.
She was coding when I got there.
So the CK here is over 75,000. CK refers to creatinine kinase, which is a protein that's actually leaked by muscle. And she mentions that the patient is in fulminant rhabdo. Rhabdo refers to rhabdomyolysis, which is widespread muscle damage. And why this is dangerous is, yes, CK is leaked, but it also leaks a protein called myoglobulin. Myoglobulin will actually go to the kidneys and clog up the kidneys, and the kidneys are this filtration system for our blood, and when the myoglobulin actually gets into the kidneys, it can damage them and cause permanent kidney damage. Here you hear the doctor panicking and saying that everything is failing, the lungs, which you mentioned before, and here the kidneys, and the patient is entering this very dangerous condition called multisystem organ failure, where you have multiple organ systems shutting down. Let's see what happens.
What the hell?
She's in VFib.
Okay, starting manual ventilation.
Clear.
The patient's in VFib, also known as ventricular fibrillation, where the heart is really quivering instead of pumping like it normally should. And the treatment for this is immediate defibrillation, which is the electrical charge, which they do right here.
Stop. Oh, she's acidotic.
Stop. Everybody stop. It's over. You've lost her. Somebody call it.
No doctor likes to lose their patient or have anything bad happen to their patient. And unfortunately, they're going to have to accept this outcome. In medicine, there are just some things that the doctors can't control. And even me, I need to be reminded that sometimes no matter how hard or how well or how perfectly I do an operation, not everything is going to come out the way that I or the patient want.
Smoke inhalation.
How did Mrs. Becker's throat look?
No, she wasn't hoarse. She wasn't
How did
coughing.
it look, Dr. Kepner?
Her breath sounds were good. She
What?
had respiratory
I'm
rates.
asking you what it looked like.
Uh-oh, this does not look good for Dr. Kepner. It looks like Dr. Weber has kind of figured out what's going on. Let's see what happens for her.
You didn't look in her throat. Because if you had, you would have seen soot. And you would have intubated immediately. And none of this would have ever happened.
That's it. I got distracted.
I know.
It was.
So it looks like the cause of death for this patient was smoke inhalation. And it looks like the patient was doing just fine for a while in the emergency room and all of a sudden became unstable. And this is actually, when I looked up smoke inhalation injuries, actually, surprisingly enough, does happen in real life. If you look at this Medscape article here, patients can appear asymptomatic on arrival, but may develop significant signs and symptoms as long as 36 hours after exposure. So this patient was not picked up as having a potential smoke inhalation injury, and nobody was thinking about it, unfortunately. Now, I don't know if I would just blame Dr. Kepner because she didn't look in the mouth and didn't see soot, and that's the reason why this patient just decompensated. I mean, there should have been other signs that she had smoke inhalation injury. So I don't know if it's very fair that we're just blaming her for not looking in the mouth as the sole reason why this patient died.
I'm sorry, Dr. Kepner.
No, I missed one step.
And look what it's led to.
So this is pretty tough for Dr. Kepner, and honestly, it's pretty dramatic. There is an ounce of truth to this, though. When we doctor, we all in the back of our mind understand that if we make a slip up or a mistake, it can lead to a pretty devastating potential outcome for a patient or, God forbid, a misdiagnosis. And so we're really taught in all of our training to be very thorough and double check and triple check our work. You know, in residency, we had a saying that, you've got to avoid the landmines. There's landmines out there that, if you're not being thorough enough, something's going to kind of pop up and bite you in the butt and hurt your patient. So try to do our best work. And sometimes you can't trust all the information that other people are giving you. So sometimes I'll be very thorough and go and double check everything myself because I want to make sure the patient has the best outcome.
Oh my God, Danny. Oh, God. Oh, you're okay. Oh, where's Mommy now? Let's go find Mommy.
Oh man, that is a super sad ending to this episode where the patient's family is going to be looking for that little boy's mom and she's passed away, unfortunately. So this is a reminder of, as doctors, that when I'm treating my patients, I'm not just treating my patient, I'm treating someone's mom, someone's dad, someone's grandparents, and that I'm really trying to make sure that I keep their family member safe under my care. Some of the best moments or even worst moments in my practice are when, after operation, I go and update the family about how the surgery went. And most of the times it's good news and the patients are very happy and they're relieved. And that's such a great moment. It's a special moment. Or sometimes I have to deliver bad news to the patient's family that there was a complication during the surgery or the surgery didn't go the way that we expected. And that's a horrible feeling. So I use that as motivation to make sure I deliver the best care to my patients to make sure that I get them safely back to their family members. So I have to give it to you guys. This episode was super intense, as you guys had mentioned. This episode was packed with medical concepts left and right. I do have to say, for realism, I think this episode did a really good job. It was 9 out of 10 is my score for realism. In terms of entertainment, when I was watching this, I was glued to my seat. I couldn't get away. I wanted to find out what was happening. It was a super intense episode. And so honestly, you guys were all right about this being one of the best Grey's Anatomy episodes. I'm going to give it a 10. All right, guys, if you guys enjoyed this Dr. Reacts video, please make sure to smash that like button, hit the subscribe, hit the bell notification so you don't miss my next one. Thank you so much for watching, and I'll see you on the next video.